Order. I call the meeting to order. This is the Standing Committee on Health. You muted that, good. I'm John A. McDonald, the MLA for Hants East and the chair of the committee. I'd like to begin by acknowledging that we're in Mi'kma'ki, the traditional ancestral land of the Mi'kmaq people. Today we will hear witnesses from mental health supports for First Nations committees. Please put all your phones on silent. Now I'll ask all the committee members to introduce themselves for the record by stating their name and their constituency. And I'll be starting with MLA Barkos.
Danielle Barkos, good morning. Thank you for coming. I am the MLA for Chester St. Margaret's.
Good morning. Chris Palmer, MLA for Kings West in the beautiful Annapolis Valley.
Good morning. I'm MLA John White from Glace Bay and Dominion. Thanks for joining us today.
Good morning, everyone. Nolan Young, MLA for Shelburne.
Hi, I'm Gary Brill. I represent Halifax Shabukto.
Good morning. I'm Laura Lee Nickel, the MLA for Cole Harbour Dartmouth.
Good morning. Thank you for coming. I'm Kelly Regan. I'm the MLA for Bedford Basin.
For the purpose of Hansards, I also recognize the presence of Legislative Council Gordon Hebb to my left and Legislative County or Clerk Judy Kavanaugh to my right. Sorry, first time I've had to chair this committee. I'd like to welcome the witnesses. I'd ask them to introduce themselves first, and I'll go from, and since I'm reading my reading glasses, Francine Vezina, thank you. I'll start with her. Introduce yourself, and then we'll do introductions after. Or, sorry, your letter or whatever.
Thank you. Good morning. Francine Vezina. I'm the Executive Director with the Office of Addictions and Mental Health.
Alexa Bagnell, Chief of Psychiatry, IWK Health.
Maureen Brennan, Director, IWK Mental Health and Addictions Program.
Lindsay Peach, Executive Director, Tajikeimɨk.
Juliana Julian, Health Director for Paqtnkek Mi'kmaq Nation and co-chair for the Health Directors.
Elaine Allison, Health Director in Wagmatcook First Nations in Cape Breton. And I'm also the co-chair of the Tajikeimɨk.
Good morning, Andrew Harris, Senior Medical Director for the Mental Health Addictions Program, Nova Scotia Health.
Good morning, Nadine Wadden, Director, Mental Health and Addictions for the Eastern Zone, Nova Scotia Health.
And also Sharon Rudderham.
Good morning. My name is Sharon Rudderham, and I'm Director of Health Transformation with Tajikeimɨk.
Thank you. Ms. Venza will speak for 1 minute, and then Ms. Peach, Ms. Julian, and Ms. Allison will share the remaining time. You're correct, Pete. What did I do wrong?
You read it out loud. You didn't have to do that.
Oh, sorry. I apologize. So, Ms. Venza.
Thank you, and thank you for the invitation to join you here today to discuss mental health supports for First Nations communities. This is an important topic, and with Sharon, Elaine, Juliana, and Lindsay here today, you have the right people. In response to your land acknowledgement, I would just like to take a minute to reflect on my gratitude to call Waverley, the place where I live, and to reiterate my commitment to reconciliation. We know that there's work to be done, and when it comes to improving access to mental health and addiction services in our First Nations, we know that services and supports must be available to meet the needs of individuals, families, and communities. And the best way to do that is for us to step back and let the community lead the way, because they know their communities best. They know what kinds of resources, tools, services, and supports are going to work on the ground, and they know how to deliver care that is not only responsive to the needs of those communities, but also grounded in culture and traditional healing. Government has a role to play to support Mi'kmaq-led, culturally safe, trauma-informed, and comprehensive, high-quality healthcare system, and we are committed to doing that. Thank you.
Ms. Peach.
We are actually going to start with Juliana, if that's okay, and Sharon will speak for Tajikeimɨk.
Sure.
Thank you.
Ms. Julian.
Gwe, I would like to emphasize the importance of the land acknowledgement. We need to remember that our Mi'kmaq Nation has been here for 13,500 years. This land is ours. We are living and working on unceded Mi'kmaq territory. Your land acknowledgement is particularly significant for this discussion on mental health for First Nations. We need to acknowledge the impact of loss of land taken with no consent has had on our mental health and wellness. It has deprived us of traditional healing, traditional food, our way of being. It is a loss of power, and it puts us as Mi'kmaq at a disadvantage from the start. To bring Mi'kmaq tradition into the room, we have brought a smudge bowl and our sacred medicine, sweetgrass, sage. Dalo Sid Juliana Julian. I am a Mi'kmaq from Paqtnkek Mi'kmaq Nation, and I am Health Director for Paqtnkek Health Centre. Elaine Allison is the Health Director for Wagmatcook Health Centre, and we co-chair the Mi'kmaq of Nova Scotia Health Directors Committee. Our committee is comprised of health directors from 13 Mi'kmaq communities in Nova Scotia. We work to enhance health and wellness for Mi'kmaq Nation in Nova Scotia. This includes advancing Tajikeimɨk and identifying priorities to improve our health and wellness systems. As health directors, we see how the legacy of colonization has led to the intense trauma and loss of our Mi'kmaq, lost in our Mi'kmaq communities. The rapid settlements of Nova Scotia drastically changed the connection to our lands, culture, health, and well-being of our people. Simply put, our culture high needs for mental wellness supports and services is a direct result of colonial policies and trauma and abuse. Our Mi'kmaq Client Linkage Registry health data shows mental health and addictions disorders are high amongst Mi'kmaq compared to Nova Scotians overall, and prevalence is increasing at a faster rate for our people. Rates of suicide and attempted self-harm in our communities are higher. The majority of our people who attempt self-harm or die of suicide are under the age of 40. People in our communities use political outpatients, mental health and addiction services at a much higher rate than other Nova Scotians. And the rate of mental health addictions-related hospitalization is much higher amongst our population. After discharge, our people are less likely to receive follow-up care from provincial mental health and addiction systems, and we are more likely to be readmitted to hospital within 30 days. Our data clearly shows the current mental health and addiction systems are not working. Mi'kmaq in Nova Scotia need mental health and addiction services and supports that are accessible and available in community, that are culturally safe and trauma-informed, and include land-based healing, ceremony, and language. By working together differently, we can ensure high-quality, culturally safe, holistic, and wellness to improve health outcomes for Mi'kmaq individuals and communities. Wulalik.
Thanks. I thought I was just checking. Ms. Rudderham.
Allison, Juliana. Gwe, Delwisi, Sharon, Paul Rudderham. I am Mi'kmaq from Member 2 First Nation in beautiful Unama'ki, Cape Breton. I am, as I said earlier, the Director of Health Transformation with Tajikeimɨk. And prior to this, I was the Health Director in Eskasoni First Nation for 20 years. Tajikeimɨk is a Mi'kmaq word that means to be healthy. We are the new and developing health and wellness organization being created to lead health transformation for the Mi'kmaq of Nova Scotia. Health transformation is the process of Mi'kmaq taking control and design delivery of health and wellness services to improve the overall health for individuals and communities. Tajikeimɨk is accountable to communities. Our work is guided by the 13 health directors, chiefs, and the Mi'kmaq Grand Council. Our work advances health and wellness as a nation. As Juliana shared, our health data clearly shows worse mental health and addictions conditions and outcomes for our Mi'kmaq compared to non-Indigenous Nova Scotians. This applies across all areas of health, and the current health and wellness system is not working for our people, and a different approach is needed. But the work of the health transformation cannot be accomplished by the Mi'kmaq alone. We recently signed a trilateral MOU, which outlines the commitment of the federal and provincial partners to take action on long-standing areas of priority for the Mi'kmaq. The first priority is addressing anti-Indigenous racism within the health system. Specific to mental health and addictions is accessing mental health through the emergency room. Mental health needs to move out of emergency rooms. ERs are not safe spaces for our community members due to racism. Our people delay seeking help or care. And when they finally do reach out, it's often at a crisis level. And then they are discharged back to community with no transitions in care or service. Another priority is addressing the gaps in services that are created by jurisdictional issues. There's always been a misconception that health of Indigenous or Mi'kmaq people is only the responsibility of federal government. But this is false. Unclear policies and jurisdictional accountability create gaps in health services for our people. And we must work collectively and collaboratively with provincial health system leadership and those who engage in policy design and health system planning to correct those misunderstandings. We also need to include Mi'kmaq voices in planning and decision-making. The relationship between the province and the Mi'kmaq is nation to nation, yet historically, we have not been included in health system planning, engagement, or decision-making. Improving mental health and addiction outcomes in communities is not about increasing access to more colonial-based services, but it's about creating a two-eyed seeing approach to mental wellness and addictions that includes culture, language, tradition. We recognize the funding provided to Tajikeimɨk through the Office of Addictions and Mental Health has created a mental health and wellness strategy is a first step in addressing these priorities, but also understand much more is needed. The provincial health system needs to be trauma-informed and needs a safe place to address racism where it exists. Tajikeimɨk provides the opportunity for all of us to work together differently as a collective in a more effective and meaningful way. Thank you.
Thank you. And before we go, I'll recognize MLA LeBlanc to do her introduction.
Thank you very much. Good morning. I'm sorry for being late. My name is Susan LeBlanc. I'm the MLA for Dartmouth North.
Thank you. So I just remind everybody to wait until your mics are recognized. Just for the people that haven't been in here before, we do 20-20-20. So at the end of 20 minutes, I'll wind up saying order. I'm not doing it to be rude, but it's to get everybody to get their time. After that, we'll do another round, which will be roughly between 7 and 10 minutes. I'm looking at finishing at 10:40, which will give 5 minutes for any closing statements that anybody has. And for that point, we will start to, is it going to be MLA Regan? So we'll start with the Liberals for the 20 minutes for MLA Regan.
Good morning, everyone. Thank you so much for coming out. And this is my first time at this committee too, so I'll probably interrupt repeatedly and get smacked down by the chair quite nicely. But so the government released this framework based on some legislation that our party had brought in. And it talks about how the healthcare system has systematically created barriers for Indigenous people. And it made me think about a conversation I had back when I was a minister with someone from another department who, just started off by saying, Indigenous people aren't showing up for their appointments. And I was completely taken aback. And I said, well, hold on there. Perhaps we should ask ourselves, if they're not showing up, why aren't they showing up? Maybe there are really good reasons. Maybe they have experienced racism in their dealings with the healthcare system. Maybe no one has taken the time to explain exactly what's going to happen. Maybe they've been in this building before and they were treated a certain way. So I was wondering if you could talk about what steps are being taken so that Indigenous people feel safe when, or are they? Are they even feeling safe when they are accessing mental health care? The conversation we had was around surgery, but it seems to me that this could be applied elsewhere. So I think to one of our witnesses from the Indigenous communities, I don't know who would want to take the lead on that.
So you're asking anyone, MLA Regan?
Whoever
wants to nod. I did see Sharon. I had a feeling I seen her. Miss Rudderham, I'll let you go first, and I'll see who else wants to go. Miss Rudderham.
Yes, as I stated earlier in my opening comments, many of our Indigenous or Mi'kmaq people who live in community often face many challenges in obtaining services outside of the community. They have to figure out ways to get there. There's issues with transportation. There are issues as well with racism. When they do access services in mainstream within the Nova Scotia health system, they do not feel safe. There are no language services that can support them within the Nova Scotia Health or IWK system. So they're not effectively able to communicate and receive adequate translation support, so to ensure that they're being understood. In addition to that, because of the multiple racist experiences that they have faced, inadequate care, our people no longer feel safe, especially our elders, when accessing health services. And as I said earlier, this often results in our people delaying access to care and then often go to access hospitals, and it's often too late. They're beyond, that they have to either go into urgent surgery or pass or go into palliative. It's not a good situation.
I'm just going to check if anybody else, does anybody else want to comment onto it? Oh, Ms. Peach.
If I could just maybe add to that, the whole concept around missed appointments in and of itself is a stereotype and racism. We actually have data that would suggest the opposite, that for some areas, that's actually less likely to happen amongst Mi'kmaq than non-Mi'kmaq. So that in and of itself is a stereotype that needs to be challenged. I think, to Sharon's point, work underway currently supported by the health directors and Tajikeimɨk together with Nova Scotia Health and IWK to attempt to address that. A number of initiatives. I think one of the things to speak to is there's work underway. We've received funding from the federal government to support the hiring of support coordinator positions. So there were 2 positions previously, but that will be expanded to locations across the province. These will be individuals that can support community members while they're in hospital with some assistance, transportation, support for their family as they're coming to visit, for instance. There's also a piece of work that we're involved with together with Nova Scotia Health and IWK and the hiring of Mi'kmaq clinical navigator positions to support individuals as they navigate through the health system. That is a complicated thing to navigate both a provincial and a federal health system. And as Sharon and Juliana referred to, there are jurisdictional gaps in the way in which that service is delivered. And so it's important for us to build the capacity within the health system as well as in communities to make sure that people have an understanding of that complexity of the health system and how they can support individuals. So those are just a few examples of some of the work.
Thank you. Oh, just a sec. Miss Julian wants to say something. Miss Julian?
I think just adding on to what Sharon and Lindsay were saying, there is work being done. There's still, of course, always going to be lots of work that still needs to be done. But I think when you look at ways in which we're accessing our services, I think it's not so much that we're not accessing, it's not accessing the right services. So we're over accessing it because it's not working for our people. So if you continuously go back to the same place and you're not getting what you need, you will continue to try with hopes that the next time will be better. And I think that is an ongoing, I think that's ongoing on a regular basis. And I the other thing I would like to say is that really, at the end of the day, if you don't offer something that is more culturally appropriate and more driven from community is not going to be as positive an outcome for it, is not going to come if you don't have the proper services that are being offered. And that really comes from community. So if community doesn't have a say over what they want to see for themselves, then that's not going to happen.
Thank you. MLA Regan.
I would say that, you know, for most Nova Scotians, the healthcare system can be daunting trying to access it. But then when you layer over the issues of intergenerational trauma, services that really aren't culturally appropriate, it must be a very difficult task. So I commend everyone who is working on this, A, and B, everyone who's trying to get help, because I think we all of us here at this committee have the goal of ensuring that the Mi'kmaq people of Nova Scotia have access to the services that they need and deserve. So thank you very much, and thank you also for correcting the record about that sort of cynical assessment that I shared with you, because at the time I was very upset and quite taken aback, and called the person out in the meeting, right? Could you speak to the issue of transportation at all? Ms. Julian, I think you mentioned you need to have services in community. And so if you don't have that, you have to have transportation. Could you speak to that particular issue at all?
Ms. Julian.
So we can, there in our community, I guess I can't speak for all communities, but we do have access to some federal funding that supports people getting to and from appointments. But at the end of the day, if you don't have transportation, if you don't have a vehicle, you can't get there. So if you have, and we can provide a community, but community access, like communities in our community, we have a community van that would take people to and from appointments. But it's a scheduling. You have 600 people living in one community and you have one van, and you're trying to make sure everybody gets their appointment. Who's the priority? The ones that got to go to Halifax because it's the specialist. Children that have to go to surgeries, anything like those are all your priorities. So everyone else who has appointments locally, they kind of get pushed to the side, and it's kind of their responsibility to get themselves to and from appointments. So, and the other thing is really, the services really need to be brought to us. Like I really think at the end of the day, services need to come to community, because community is already feeling like they're not accepted in those settings, so bring them to the settings where they do feel comfortable. And it's a challenge even to get community to open up to people in healthcare systems to begin with. So trying to get them to trust them enough to help them in mental health and addictions, when everyone knows mental health and addictions is very personal. So those are very personal things, and relationships need to be built. And it may not even need to be built with the professionals that we're provided from the Nova Scotia healthcare system, I guess. So we need more traditional healers, more access to land-based learning. Our children, we have fastest growing youth population, and yet our ability to access IWK services is a little, not as good as it should be. If we had services in community, maybe we would be able to help more of our young people. So I guess I'll leave it at that.
Mr. Rudderham wants to make a comment. Ms. Rudderham.
Thank you. I also want to add that the current system that NSH and I guess IWK as well has in place, I know that those systems are working to become more trauma informed. The issue specific to mental health and addictions issues, you have to tell your story over and over and over and over again in order to get on the pathway to where you need to go. So that is not a trauma-informed approach. If you have to keep re-traumatizing and telling your story over and over and over and over again to multiple providers to obtain a pathway to care, it does not create a trusting relationship. You feel like you're going through an assembly line system. And it does not allow us to build those relationships. Whereas in community, if those services were available and were provided, you can build on those relationships. NSH has also, they have very strict rules around, seeing as many people as they can see, and you can only see so many people for so many visits, and then you have to like move on through the system, or if you miss an appointment, then you have to, it impacts your care. So that being trauma informed is also another big issue. And being able to, like Juliana said, the need to establish a trusting relationship cannot be created if they're not trauma informed.
Thank you. Oh, Miss Allison. Miss Allison, there you go.
Thank you. I just wanted to add that we really need to meet the clients where they are. So we need the services right in the community. Like, it's not fair to take someone to the regional hospital, our regional hospital. The issues we have in the ER, they sit and they sit and they sit. They don't want to stay any longer, and they walk out, and then we're in trouble. We get them, they come back to the community, and then we have to deal with everything. So the continuity of care, the collaborative care, we need to all work together to help the clients exactly where they are. So maybe it means I'm a registered nurse in the community as well as the health director, so I know that sometimes we just go for a drive and we talk. The clients, we take them for a drive, we pick them up and we say, well, you want to go to Tim Hortons? We go to Tim Hortons and we have a coffee, if that means that we get in and we get to talk to the clients. But lots of providers will not do that, but we need to do that in our communities. Thank you.
Thank you. MLA Regan.
Thank you for that really good explanation. There are a number of different aspects, so I'm going to try to delve into some of those a little bit further. What Ms. Rudderham was saying reminded me of what we say about sexual assault victims. If you have to retell your story over and over again, you're reliving that pain, you're reliving, excuse me, that trauma, and that's not good for healing. So, Ms. Allison, you talked about going for a drive. If I were to say to you, what would a successful mental health clinic in your community or a series of supports, what would they look like? If I said to you, okay, what do you need? What would be what you thought was the best, what you're looking for?
Miss Allison.
So first, I'm not Indigenous, but I've worked in this community for 25 years, and I did outpost nursing in the north, so I've been over 30 years in Indigenous communities. My dream would be to have a separate, not a separate building, but an area, a culturally safe area with all the traditional healers available. And if it's a traditional healer you need right now, or you need a social worker, or you need a clinical therapist, or you need a psychiatrist, one-stop shopping. You can come, the physicians in the community, the psychiatrists that we have that comes to the community, we would be able to have everybody together, and you would only have to come. So the community that I work in is only 1 mile long from one end to the other. So I'd be able to bring the client right to pick them up, bring them to the health center, but in a safe health center, not a health center that looks like a hospital. And I don't like that. I think it needs to be culturally safe and built by the community, and I would like to have this area where everyone can come together, and you would have drumming, you would have a sweet grass, you would have You'd have the sweat lodge. You can do whatever the client wants to do first, if that's what they need, and then move on to our modern medicine. But I think we need to use traditional medicine more.
That's what I was going to ask you if you wanted. Anyone else want to comment onto it? Miss Julian?
I think the other thing is we're already making the assumption that we know what we need. We're not even there. Sometimes we're not even there. So trying to take the time for them to be able to build the trust is huge. And whether that's traditional healers, because that's been taken away from us as well. So we're reintroducing our people to things that we don't know the benefits from until we've actually been able to access it for our own healing purposes. And I think that once we give our community members the flexibility and the ability and the services, and that it's there for them to decide where to go with it, then I think that that's the only real opportunities that we're going to have for true healing in communities and for our people, especially our young people. I think young people especially really need the support of their family, and if that's not their mom and dad, then it's the extended family. And I think it's really important to realize the importance of extended families in Mi'kmaq communities.
Oh, Ms. Peach.
If I could, excuse me, if I could just add to that as well. I think one of the things that we hear from health directors is in relation to crisis supports. And crisis in Mi'kmaq communities look different than crisis in non-Indigenous communities. And so every death has an impact, and a significant impact to that community because of the loss that it represents to the family and to the community and to culture and knowledge at times. And so that is one of the things that we've been working with the health directors and sort of exploring what does a crisis response and support service look like. As Juliana and Sharon said, and Elaine as well, it is more than bringing Western medicine to community. That is important, but we also need to take a two-eyed seeing approach to what the services look like.
Thank you. MLA Regan with minute 10 seconds.
So we're not going to get a fulsome answer on this, but I was just going to ask about young people, about accessing mental health care in schools. Does that happen? Is it possible? What would you like to see? You could get started on the answer.
Well, who wants to take that one? Miss Julian.
More help, more services, accessible to proper services, community-based services. There's much more that you can offer and much more that you can't. There's so much that our young people need that they aren't getting now. We have kids that are in group homes. We have kids that are removed from the home for mental health issues, and there's no real access to services for them. Not enough.
Thank you for not talking to me, having to say order. I looked at the clock and going like, this is not fun when you have to say it. So I'm assuming with 10 seconds, okay. So MLA LeBlanc.
Thanks very much, Mr. Chair, and thanks again, everyone, for being here. I just wanted to ask, I mean, I was going to ask this question that MLA Regan did about, like, in a perfect world, what would adequate and more than adequate services look like? And we're getting to it a little bit. But I guess hearing the answer that was just given from a variety of people, or from several people, and I missed the opening, sorry, but what are the obstacles? Like, so to get from where we are to where we need to be, or where you need to be, what's required? Is it people? Is it more money? Is it commitment to bricks and mortar buildings? What would be necessary to get there?
Who wants to take that one? Oh, Ms. Peach.
I can start because we've had lots of conversation about this as well. I think not even specific to mental wellness resources, but more broadly, the funding that's been provided to communities historically tends to be for planning and with never the money to implement, or short term, so it's, you know, a 2 or 3 year pilot project. I hate that word. But with ever the plan to sort of learn from that and sustain it. Or in cases, particularly I think with the federal government, sometimes with silos and the way that funding is allocated. And so in a small community, trying to patch together all of those portions of funding to do something that's impactful and sustainable is really difficult. I think that's part of the opportunity that presents itself with health transformation is to do that differently. So it is in part the funding, but also in part the people to be able to do that work. So, you know, ideally there are many of us who are not from community but work and support community. But ideally we would have community members in those positions. And so building the capacity of community, youth and community to enter into the health professions in a variety of ways is part of the work that we've taken on as a health organization. So, you know, working with our university colleagues, we have designated seats in many of the health professions, but not necessarily great process to make sure that Mi'kmaq students are prioritized for those seats, or that there's a good process to make sure that the right people are in those seats and that we're supporting them as they're applying to those health professions, as they're in the education programs, as they're in their practice settings, and as they transition into employment. So it is very much a part of the work that we see for our organization is to help build that capacity so that when we do have the resources, we also have the people that can deliver that service in community.
Anyone else? Emily LeBlanc. Oh, just a sec, sorry. Ms. Rudderham threw her hand up. Ms. Rudderham.
Thank you. Sorry. You know, really, with response to the question that was asked, we require community-led mental health and addiction services. We do require a two-eyed seeing approach where we're also offering Mi'kmaq and traditional and cultural services and supports, but we're also offering Western, clinically based services and supports. So we require a combination of both services broadly across all of the communities that are, again, like I said, trauma-informed and culturally safe. In addition to that, we also need an effective way to respond to crisis in community, because our communities regularly face crisis situations and they have impacts. When there's a death or a suicide in one community, the impacts are throughout the entire nation. So when you lose one person in one community, our families are all connected. And so we are all impacted. So, you know, understanding how there would be so much compounded grief impacting our communities, which often lead to crisis situations. And we need a mechanism, and we need community-led services and supports and infrastructure to provide those services directly within the community.
Thank you. Emily LeBlanc.
Thanks. One of the things that I was working on for a while, I forget in what critical role I was thinking about this and doing this, is a sort of an overhaul of the emergency 911 system to include mental health response, which is different than the mobile crisis program that we have in HRM. So, and one of those things is, you know, the idea would be that, like, you call 911 and they say, what's your emergency? And you say it's a mental health emergency, and they don't dispatch police or fire or ambulance, they dispatch a mental health emergency worker. And so I'm wondering if if that sort of community-based approach, so if someone in a particular particular First Nation calls for mental health supports, that there's a community approach that's an emergency response. So like it wouldn't be removing the person and taking them to the local regional, because as we've heard, ERs don't work for mental health emergencies. So I'm wondering if someone wants to respond to that idea, and or is it actually being worked on right now? Is there something in mental health emergency being worked on in terms of community-based treatment or response?
Oh, okay, so Ms. Rudderham put her hand up first, so I'll let her go first. She's laughing.
Thank you. Well, within our communities, crisis response has been an ongoing challenge for our communities. You referenced the HRM crisis service that's available. You know, that's only available within HRM. Right now, if we were to call 911 for those services, it would be police that would be dispatched to our communities. And there are long-standing issues with our police as well, within Indigenous communities. You know, we can refer to many, many reports, Donald Marshall Jr., all kinds of other reports that have been done with relation to the relationship between police and Mi'kmaq communities. So a police response is often not a safe response in our communities. I worked in Eskasoni for 20 years, and when Eskasoni was dealing with their crisis, they established the Mi'kmaq or Eskasoni crisis line. That crisis line hasn't received any kind of consistent or sustainable support to operate or to function or to grow. The Eskasoni crisis line was the only service that was culturally safe, that you could speak to someone in your own Mi'kmaq language. And then they would often, you know, support individuals, and they would try to de-escalate and work with mental health clinicians and refer them off to mental health clinicians in the community that the patient is living. But the lack of support to create a system specific to the Mi'kmaq, like a crisis line, is an important and essential component, I think, in being able to provide an adequate crisis response that is available in Mi'kmaq, which is, again, which I stated earlier, language services or translation services are not available in the Mi'kmaq language within the Nova Scotia healthcare system. 911, 811, any system does not provide any Mi'kmaq language services.
Thank you. I'm looking. MLA LeBlanc.
Thanks for that response. I mean, I think that's a really big deal, not having translation services. And I think this is something that has to be a #1 priority for the Department of Health and Wellness and the Nova Scotia Health, because you know, it is the first language of the territory we live in, and if we can't provide services in the first language, then we got a real problem. And I think that needs to be a high priority for the government. So thanks for bringing that to light, Ms. Rudderham. Sorry, I lost my train of thought. This idea of the sustainability of services and this idea that there's money for pilot projects. I mean, listen, I come from the arts sector, so that's basically the only way the arts sector has been funded for many years, so I am so frustrated by it. It's so bad. And so is there a discussion? I guess the question really is there someone of Mi'kmaq heritage in a high up position in Nova Scotia Health that is like positioned there to say, don't forget that we need these things when planning and policy is being made. Don't forget about the Mi'kmaq nations and even the people who are living off reserve. Like, don't forget about that. Is there someone in the department or at Nova Scotia Health responsible for that?
Your question is to?
Anyone, someone from Nova Scotia Health or
Well, I don't, if nobody does, I guarantee I can see Miss Rudderham nodding. So if nobody else goes, I'm gonna be saying Miss Rudderham. Miss Rudderham.
Yeah, no, there are no Mi'kmaq or Indigenous people within senior levels within the NSH or IWK system. And I think that that's a big gap in our system. How can we effectively impact change or direction comes from leadership within your health system. If we have no Mi'kmaq leadership at that level, then it's not being addressed.
MLA LeBlanc with 8 minutes left.
Thank you. Yeah, I agree, and I think that is something that we need to address at the government, at the department level, the IWK level, the health authority level, so that we can have that leadership at the top, bringing that voice and that lens, definitely. So I also want to talk about the sort of like what do you call it, like reserved seats for education for healthcare workers. So Ms. Peach, you were saying that there are designated seats, but maybe not prioritizing Mi'kmaq students. So are the designated, who are the designated seats for if they're not prioritizing Mi'kmaq people?
Ms. Peach.
So a number of the programs recently have announced sort of designated Indigenous seats or seats available for Indigenous candidates. Recently, Dalhousie Medical School has established an Indigenous pathway that would go with those seats or support those seats, and we've been involved in some of that work with them. And that actually has community members who are formed part of a panel that help make the decision on individuals that have applied and who is best and most appropriate for those designated seats. And that matters because, you know, whether we like to admit it or not, there are individuals who claim ancestry that aren't of Indigenous ancestry or have a connection to community. So it's really important for us that there, in addition to the designated seats, that there's a process for selection to make sure that students don't continue to be disadvantaged during that process, and that they understand that there is a system and a support there for them when they do self-identify. So asking students to self-identify during an application process to a health profession actually puts a target on them if they know that they're likely to experience racism because they've self-identified. And so if you're going to ask people to do that, then you need to put the supports around them as well. And so what we have said is great that there's programs that have designated seats, but let's try to do the work to put some process around it. So we've done some work specifically around nursing with the support of the Office of Health Professional Recruitment, Department of Health and Wellness, and Advanced Education, working with the schools of nursing to say, is there something that we can do that will support that application process, but also more importantly, support the students when they're in the programs. And so I would like to see every time that there is a new program, a health profession program that's announced with designated seats, that there's also a consideration of what that means and what supports you're going to put in place to actually support those students that are self-identifying.
Good, Ms. LeBlanc? MLA LeBlanc.
Yeah, thank you. Thank you. Yeah, so two follow-ups. Are there designated seats in the social work program and at DAL? And second follow-up is, what is the percentage of designated seats? Like, so for a medical school, what's the percentage of designated seats versus open seats, for lack of a better description? Maybe for nursing, medicine, and like, I don't know, pharmacy.
Ms. Peach?
So I may not be the best person to answer that. That may be a better question for advanced education. I think they would probably have the summary of sort of the numbers of designated seats by program. My understanding is that there are designated seats within the social work program, both at Dal and the one that's being established at CBU, I think. And so if I understand that correctly. So I think there are a number, but that may be a follow-up question that I wouldn't want to misspeak.
Thank you. Emily LeBlanc. Oh, hold on. Ms. Rudderham, did your hand flip up when I looked over?
I just wanted to
Ms.
provide
Rudderham.
clarification. There is a Mi'kmaq or Indigenous social work program within Dalhousie, within the School of Social Work. That is specific to Mi'kmaq and Indigenous people.
Thank you. Emily LeBlanc with a little over 3 minutes left.
Okay, thank you for that clarification. That's really helpful to know. I'm wondering about data collection in general. So, Ms. Julian, you were talking about data collection in your data shows, and I was like happy to hear that you're referencing data, because for a long time there was no data being collected in a number of different streams in the health system. Who's collecting that data? How long is it been collected for, and is it working? Like, it sounds like it is. Sounds like you know lots from the data, and yeah, I just want to dig into that a little bit more.
Ms. Julian?
I am actually going to refer this question to Sharon. Sharon has been in the data collection business a lot longer than Paqtnkek.
Well,
we kind of joined in on them. We kind of hopped on their coattails.
Well, she kind of put her hand up, but since she said you, I went to you first in this case. So, Ms. Rudderham.
Thank you. With regards to data collection, the Nova Scotia Mi'kmaq have been working for many, many years in collaboration with the Department of Health. We have developed what's called the Mi'kmaq Client Linkage Registry, and that allows us to be able to extract information from provincial data sources. And now it's beyond Department of Health. It also includes Nova Scotia Health and the IWK. It allows us to, and the Department of Health, business analytics, I'm not sure what the name is, but they provide the support for us, and they work collaboratively with us in the development of and the selection of indicators and the development of various reports that are reviewed by our communities. And the same process is done with NSH and IWK as well. So we have that's what our data system is. And yes, the data is very extensive. It's all of the various programs within the provincial system that currently collect data.
Ms. Peach with 35 seconds.
I'll add to this really quickly. It is a gold standard, that client linkage registry and the information that it contains. It is what every other First Nation organization across the country in health transformation is striving for. And the Mi'kmaq of Nova Scotia have it already as a foundation for the health transformation work. So it's pretty amazing.
Thank you. Emily LeBlanc with 10 seconds.
That's fine.
Okay. MLA White.
Thank you, Chair. So, very interesting conversation. I'm sitting here listening to mostly the value of community. That's what really gets me. I think that's core in everything, but you folks have made that extremely clear today, which is obvious, of course, but nonetheless, it's nice to hear you talking about it. So, Ms. Peach, my first question, I only have two to start with, is I'm wondering about the mental health addiction strategies for Indigenous people. Are you able to tell us a little bit about consultations that have happened or work that's been done on that file already?
Sure.
Thank you.
Ms. Peach.
Thank you for the question. As was said earlier, we certainly acknowledge that any mental health and addiction strategy and work that we do needs to be more than just bringing Western medicine to community. That is a piece of it. But we also need to bring a two-eyed seeing approach and cultural and traditional healing and practices back as well. That's a big part of our work. So we were fortunate. We received funding in March of 2022 from the provincial government to develop a Mi'kmaq mental health and addiction strategy. And that really built on years of work that the health directors had done previously, and some collaboration as well. There was two integration fund, federally funded initiatives where the province worked and the health authorities worked with the Mi'kmaq communities around identifying needs as it relates to mental health. So what we've done so far with the strategy is taken a look back at some of that information, that previous work that was done, to see what's been achieved and what's still outstanding. We've also looked at the data from the Mi'kmaq Client Linkage Registry, which is a wealth of information around needs and outcomes and utilization of services. We've brought together the 13 health directors representing the community, as well as representatives from a number of partner organizations, so Nova Scotia Native Women's, the Mi'kmaq Friendship Centre, NADICA, which provides treatment center services to communities, brought all of those groups together to identify what are the current priorities, what's been done and what's left to do. And so that sort of formed the initial foundation work. The other consultations we've done, not specific to mental wellness, it's hard to separate mental wellness and healing from the rest of the health transformation work that we're doing. We had a Maui-Omi last year, a large gathering, about 300 people, representatives from community and leadership coming together to advise us on their priorities for the organization and our health transformation work, and that really reinforced some of the priority work that the health directors had shared related to mental wellness. We've also done a knowledge gathering, so we've brought together elders and knowledge keepers working with the Confederacy of Mainland Mi'kmaq and the Union of Nova Scotia Mi'kmaq to learn from those knowledge keepers about traditional practice as it relates to mental wellness and healing and land-based healing, and how we can bring some of that work back and support it and build that capacity. And so that's another consultation that we've done. We're also in the process right now. We actually just returned from 2 days in one of the communities, so we're doing Maui-Omi Gij community engagement in each of the 13 communities as well over the next 2 months. So we're busy with that, and that is also reinforcing all of the messages about youth services and the need to support youth differently. So we'll compile all of that information then ultimately into a strategy, but this will look different than other strategies, as it should. As Juliana said, it's really important to reflect the needs of the community in that work.
MLA White.
Thank you, Chair. I'm extremely happy to hear you talking about how much the community has been involved, because that is what we're talking about when you're talking about a counseling session. It doesn't matter if it's a walk and talk or sitting across a desk. It's that trust that these folks were asking about earlier, and that's what you're talking about there. So I hope it does look different. I really hope it does, and I hope that you keep your gas and your foot on the gas. Keep us to the pedal. So my next question, anyway, is can you tell us? I understand an MOU has been signed with the 13 First Nation communities and the federal and provincial government. I'm wondering if you can give us a little idea on the improvement in mental health and addiction service that may have for Indigenous people.
Ms. Beach.
Thank you. Happy to do that. So the MOU that was signed, 13 Mi'kmaq communities in Nova Scotia, as well as the provincial government and the federal government, is part of our health transformation process. So as Sharon referenced, health transformation for us is the transfer of federal funding and responsibility to us as an organization to deliver on behalf of the Mi'kmaq of Nova Scotia in a very different way than what's previously been done by the federal government. So similar to the work that was done in BC with the creation of their First Nations Health Authority. We will be the second province-wide First Nations Health Authority to British Columbia. There's a few other initiatives in other jurisdictions across the country. So the MOU was critical to that work. It's the first step in the health transformation process, and we acknowledge this is bigger than, as Sharon said, this is bigger than just the transfer of federal responsibility. This is working with our provincial partners differently, and so I think the MOU signifies the coming together of the parties to work differently, but we've also been able to demonstrate through action working differently. So we now have committees with senior leadership within the health system where we have an opportunity to explain the jurisdictional gaps and the challenges and address some of that work. You know, we've worked on policy changes in the home care space, for instance. One of the areas I think with mental health, in addition to the strategy, there were recently opportunities sort of before the MOU to expand access to Western services into community, and there's been lots of conversation around how that can shift and grow and expand. I think, you know, there's been conversation around, as Sharon said, how we can sustain and support the Mi'kmaq crisis line that's delivered through Eskazoni. What does that look like? So I think we've been, the MOU and our establishment as an organization has created space and in conversation and planning discussion in a very different way than what the communities would have done before, and that's created lots of new opportunities to be part of service planning conversations.
MLA White.
Thank you, Chair. I really want to take more of your time, but I know I have to pass it along to Emily Barkhouse. But that you said it was critical. It's critical to making real change. The work you're talking about is amazing. Thank you very much, Emily Barkhouse.
Emily Barkhouse.
Thank you. The four of us have to share the 20 minutes, so I try to be equal. So my understanding of the two-eyed seeing approach is that one eye sees through Indigenous and one eye sees through the Western, and they come together to try to see the perspective. And please correct me if I'm wrong, because that's just what I know. But I'd like to ask about the two-eyed seeing approach and how that is incorporated into health for communities. And that can be to anyone who wants to answer.
Who wants to answer? Miss Rudderham's smiling. Okay, Miss Rudderham. They're deferring to you.
Yeah, I know. I can start and others can add. You know, the two-eyed seeing concept was really developed by elders Albert Marshall and his wife Medina Marshall, who are from Eskazoni First Nation. And, you know, I've had many discussions with Albert and the late Medina. My understanding, you are correct in your interpretation. It's about bringing those two worlds together and figuring out a common path and to figure out how we can utilize both worlds to achieve better outcomes and better healing pathways for all of our people. You know, we have strong connections to our culture and our land, and you've probably heard of medicine wheel, the medicine wheel. You know, that's a concept that is you've heard of in other Indigenous communities, but it's about creating a balance. It's about creating a balance. It goes beyond, it's just not your physical illness, or it's just not about your physical symptoms. It's about finding balance in your being with, you know, your mental, your spiritual, your emotional, your physical. You know, it's about creating healing pathways and working together in two worlds to create a pathway for, you know, specific to mental health and addictions, about creating those pathways that can support the overall individual's healing and wellness.
Miss Julian.
I think just to add on to that, even two-eyed seeing is even just, if you go even one step further, it's acknowledging that Indigenous people, First Nations people, Mi'kmaq people, we had our own medicine. We had our own way of healing our people when they were sick. It's acknowledging the connection between the stars, the land. And I know that sounds like, oh, that's all EBGB, whatever you want to call it, but the connection is there, and the healing opportunities with the way our moon is at certain times of the year, and our prayers and all of that, and our connection to the land, it's all there. And we had a way of being able to heal ourselves and heal our people. We just don't, it's hard to try and go back to something that was taken away from us so abruptly. So trying to reintroduce those not only to society, but to our community members, and acknowledging that our medicines actually do work, and they probably work even better than Western medication. So that's just one step further, I guess.
Thank you. MLA Barkhouse.
So the Baby Smiles book, kind of love this a lot. Well, not kinda, but it's, so let me try to put my words around what I'm thinking. It's a project that work partnerships that went into creating this. On your website, you mention, so there's where my notes come in. Actually, on your website, you mention the partnership aims to create a new way of thinking about health and the delivery of health services. I'm wondering, and I'm pretty sure it'd be Miss Beach, if you could elaborate on this, because I think it's absolutely wonderful.
Miss Peach.
I can start. Sharon may want to add to this too, that this was an initiative that started when she was health director in Eskasoni, the book. So for those that don't know, you know, in amongst all of the other work that we're doing, we also published a book in our first 2 years as an organization. But I think it demonstrates the innovation from community to, you know, to sort of step in, see a need, and do something really creative in terms of how that need is met. It is an example of bringing culture and language into the work that we do, which is part of the larger and broader work of health transformation. But Sharon, did you want to speak to the details of the project? We're pretty proud of it.
Ms. Robertson. Rudderham, sorry. Thank you.
Thank you. Yeah, the reason that, you know, I started this plan or this idea was related to, of course, you know, the data informed us that many of our people were accessing emergency rooms for dental services. So we're like, that's completely wrong. Why are people going to, I know it's an urgent issue and whatever else. And we really, you know, access to dental services has been a challenge for our people. They face racism when going in to try to access dental services as well. Not all providers are willing to accept our plan and refuse to provide services to our people. In addition to that, we were also, you know, there's been a lot of related trauma related to dental care because of the Indian residential school system. That has impacted generations of our people. So with that, we're now seeing increased numbers of emergency room visits because of dental issues. We're also seeing increased numbers of children going to the IWK to access pediatric dental services because of tooth decay and so, you know, we have developed maternal child health and early years services in our communities. And I thought it was essential that, you know, it needs to start at an early age, education around oral health. And so we figured, books are distributed as a resource through our Children Oral Health Initiative team members or our maternal child health or early years team members that work in the community that could have a resource to share with families who have new babies. And like the other members said, we have some of the fastest growing population and the highest rates of births in our community. So we thought it was an essential resource that needed to be developed and shared. And we're quite happy with the result. And there's been lots of requests from right across the country to look at translating the book into other Indigenous languages as well.
Thank you. Emily Barkos with 3.5 minutes left.
Well, I'll just be quick because I do have to share my time. I can see the pride and the love and commitment in your guys' eyes. So, and I understand why. So thank you for talking a little bit about that, because I don't think a lot of people do know. And so thank you. And I will pass it over to MLA Palmer.
MLA Palmer with 3 minutes, 10 seconds.
Thank you, Chair. I love this committee. I love being on this committee and just learning so much every time we come in here to meet with different groups or stakeholders in healthcare. And today is no different. I mean, to learn about the health needs in your community. I represent Annapolis Valley First Nation in my constituency, and at a powwow last weekend, I actually had a chance to meet a lady who was there promoting the medical sciences pathway at Dalhousie. And I think that's part of the question I want to ask, because you've hit on a lot of the things I was going to talk about here with the seats and with the Dalhousie program, and you've also talked a little bit about the importance of Indigenous representation and care in your community. And I was going to ask maybe Ms. Peach if you could expand on that and the importance of having First Nations people in their community delivering those health services, understanding that we're still, you're moving towards traditional health care and exploring that, bringing that forward. But as far as the promotion of health care in First Nations youth or mature students, can you talk about how you're doing that more? I mean, I met a lady who was at the powwow talking to people, but can you talk about how that's being promoted to people, those opportunities in healthcare in First Nations?
With a long preamble, 1 minute, Miss Peach, he knows why I grilled him. Miss Peach, and for 1 minute, 30 seconds.
I'll try to answer that quickly. I think representation and people seeing themselves in the positions that they aspire to is important. And so, we've done work around promoting young Indigenous nurses so that others can see them as role models and supports. And so that is important. It's important to have that in all aspects of the health professions, not only for services and community, but it improves the services in the rest of the provincial health system too. Having Mi'kmaq health professionals working in the health professions, in the health across the rest of the health system matters and is important, and we all need to support that. I think the work that we're doing to encourage youth to pursue careers in health professions. A lot of that is done through partnership with other organizations. So whether that be the education system or the post-secondary system, the health directors do a lot of that work in their communities, as well as do each of the individuals that are working in those communities, spend a lot of time supporting other youth in the communities that are aspiring to enter into the health professions. I think some of the things that have happened recently, we've got cohorts within the nursing program where that education started within communities. So
Order. Apologize. I know how you feel now, Emily Reagan. So the next round is going to be 9 minutes. We're going to go to 10:41. And MLA Nicol.
Thank you. And yes, I'm not on the committee, but I fully agree that health is everything. And health, the saying is sound mind and body. So it is how we all have it in balance. And, articulating 13,500 years, generational trauma, that's a lot of years and a lot of trauma. And so I want to premise that, because at the end of the day, generational trauma is insidious. Our children pick it up and we don't even realize they're picking it up. And that's, spoken from experience. I want to ask, with regards to, as a woman, but as an Indigenous woman, there was a study done in 2019 that said that Indigenous women are more likely to have mental health issues around the birth of a baby. And 62% were at increased risk for experiencing mental health problems like depression, anxiety, and substance abuse. And I just wondered how everyone that's here is working with the IWK or other hospitals with regards to, pregnancy care, how that is being looked at. I mean, except for one gentleman, we're all women here, so I really wanted to ask that.
And who did you want that asked to? Anybody who wants to, is that?
Well, I guess, and I would like to give an opportunity, because I want to, compliment each of you who are doing the grassroots work in the community. But we have two, I think, from institutions here that I would like to speak from. So I'm hearing a lot from the bottom up, but I now want to hear from the top down. So there's two doctors.
Pick one.
Well, it's women issues, but then again,
All right, so
they can both go.
I'm going to go with Dr. Alex Bagnell. Bagnell.
Close. Thank you. So I can speak to our program at the IWK on reproductive mental health. So we have a group led by psychiatry, but with multiple disciplines, who work with women who have either mental health issues or developed during their pregnancy, and they follow them pre-delivery and then a year afterwards, and they do a lot of outreach in the community. And also on the team, there are no Indigenous clinicians, and I will say that's across the health center is an area that we're really working on, because a lot of people walk into services and don't see themselves, and that immediately makes it feel unsafe. And that's not just for Indigenous, but other minorities and people who have been racialized. But with our reproductive mental health, they do a lot of outreach in the province space as well, and work with family physicians primarily in terms of early recognition and then maternal health and well-being, because that makes a huge difference in that first year, which as a child and adolescent psychiatrist, I can tell you is incredibly important for the long-term development of that child and their mental health, but also their overall health and well-being. I'll stop there.
Thank you. I assume you'd like Dr. Andrew Harris, MLA Nickel?
Especially the latter part of my question, where with regards to not just depression and anxiety, but substance abuse, because I see your addictions as well, so I wanted you to sort of elaborate on that.
Dr. Andrew Harris.
Thank you, and I am unqualified being the one man on the committee today. I think it's a good question, because really to speak to the relationship that we have amongst the two authorities of sort of mental health and Tajikeimɨk, we have worked very hopefully closely and collaboratively. We have learned a tremendous amount about how we provide our systems of care, and I really would endorse the two-eyed seeing approach, which is to look at this through both lenses. We're very fortunate to have this group of individuals, the health directors and the executive in Tajikeimɨk, who are great guides for us to tell us what we need to do, how we need to provide services, and we're completely on board with the approach that's being taken. With regards to specifics around women's health around peripartum, I don't know if I could give you a specific answer that would sort of answer your question, but I think your broader context for this question, which is how are we working together? I would say we're working together very effectively. We have a lot of work to do. We've been at it for a while, but this type of work does take time.
Emily Nickel with just under 4 minutes.
Thank you, and I want to express to Juliana, thank you for that approach about, because a lot of times when it comes to mental health, a lot of it, we don't trust the healing. And so a lot of the medicines that the Indigenous community, we could benefit from. And so how that whole two-eyed approach would benefit everyone at the end of the day. I guess my question, like the whole thing with, because I grew up in on Alma Dam, a little Acadian community in Cape Breton, and dental health is hard to get. And so is there anything to expand on what we discussed about dental health? Do we have to have a seat for, like, to get dentists from the Mi'kmaq community?
And that's to,
they're already nodding, so.
Well, you say that, I think I seen Miss Rudderham's hand go up, so I'm not sure if she wants to speak to it. And they love deferring to her, so Miss Rudderham.
She brought it up.
I think there is work that needs to be done. I would like to see some work, based on the learnings that they have completed in Dalhousie and the learnings that we're going to achieve through our relationships that we're building with the nursing schools. I would really like to see it go beyond those two areas and see it further expanded. I think that there's definitely a need for improving a pathway to ensure that more Mi'kmaq or Indigenous people can access or obtain their dental qualification or certification. We have just recently also began some discussions with the Nova Scotia Dental Association and the Regulatory Board, and they're going to require a lot of education. They were not really aware of the racism or the issues that our patients our community members were facing when being refused services and they wouldn't term it as refused services. They're refusing our dental program, which is a federally funded dental program, similar to what your provincial dental program, but they still have the ability to refuse our dental program. So I don't know if there's something that can be done around that point, but there is a tremendous amount of work that still needs to be done with relation to dental services.
Emily Nicol with 1 minute, 3 seconds.
Well, and I'll only, to that point, I'm just going to say I have adopted saying the word orders of government, and I know the Prime Minister, I think I escalated it to there, that because he says it, because at the end of the day, we are all orders of government, and it includes the Indigenous community as an order of government when you use that term. So that's all I have to say at this time, but I'm impressed and I'm encouraged, but there's a lot more work that needs to be done.
Thank you. Emily Burrell. I know.
Yeah, thanks. I certainly feel very aware of the breadth of expertise that's represented by all of you here this morning, and I did want to ask about initiatives in suicide prevention in First Nations communities, about how you would characterize the adequacy of the work that's being done, or what is some of the strengths about it, and some of the areas that we can see where improvement is needed, and I'm unsure who to best direct this to.
Who wants to? Oh, well, do you want Miss Julian, or do you want me to? Okay, that's right. Over to you.
Oh,
you're still muted. Oh, what? Oh, Miss Rudderham.
Okay, thank you.
Sorry, I thought I did.
Okay. Yes. A lot of some of the resources that we receive from Indigenous Services Canada, Health Canada, the funding that we do receive to support mental health services are for upstream services. So that is to support suicide prevention training, assist training, various other types of training programs that we can offer in our communities. But, you know, of course, that's very minimal. But I also would like to talk about the importance of being able to have an effective response in community when there is a suicide. You know, it goes beyond more than prevention. You can do prevention and education, but the ability of communities to have an effective response mechanism when a suicide does occur, or the ability to have a crisis line available 24/7 that is sustainable and funded and supported, you know, are other factors. I think that, you know, our communities have also done significant research and worked in the research field around looking at models of care with relation to youth suicide. And one example that I can refer to, when I worked in Eskasoni, we were involved in integrated youth services and the ability to have youth services and supports provided to young people in the community through bringing kids together for various learning and teaching, suicide prevention, but also other opportunities to learn about culture and ceremony and others. But the model in Eskasoni was where they would provide clinical supports in that same location and be able to build those relationships and build those trusting relationships between young people and youth in our communities is also essential. And, you know, I was pleased to see that the Nova Scotia government had supported the rollout in the IWK of the Integrated Youth Service. So, and we're looking forward to that work expanding and being able to be provided within all of our communities here in Nova Scotia, our Mi'kmaq communities.
Thank you. Ms. Julian, did you go good, or did you want to add anything? Ms. Julian?
I guess just to add on to what Sharon was saying, I think crisis teams really needed in community, crisis teams that can respond in a different manner than what we would get accessing services at an ER. And even we get to the ER and it's not quite, I shouldn't say, it's not adequate services for our community members. And I think that some of the work that communities are doing in trying to respond to suicide in our communities is crucial and hugely needed. We do have many suicide attempts, but we have just as many, like in our community, we would have had, it would have been new for us to have suicides. We've never had any, and then boom, we got 2 of them back to back really fast. So being able to respond in a way that it's really is mindful of that it's a trend, it ends up as it has a trickle effect. So I guess us trying to really put some investment in crisis response teams, which is one of the biggest reasons we're really pushing to try and get crisis response teams in our communities, because it's greatly needed. And I think we can't always respond to our own crisis within our own communities, so we look to our neighboring communities to come into our community. NSHA is really good to say, you know, is there something we can do? And I want to say yes, but they can't respond in a way that our own people respond to each other when we're in crisis. So I think that's one of the biggest things. I think we're really moving towards trying to create those crisis teams within community so that we can have community members helping each other all across Mi'kmaq.
Thank you. MLA Burrow.
Thank you. I'd like to ask too, you know, in the TRC calls to action, the mental health figures pretty prominently, and a lot of calls on orders of government for initiatives and programming. And so I'd like to ask whoever would like to offer a comment on this about an assessment where Nova Scotia is. A kind of a thumbnail report card. Is Nova Scotia at the head of the pack? Are we somewhere in the middle? Are there particular areas where we've fallen short of what the TRC has called for in mental health?
Oh, okay. I see Miss Rudderham's hand goes up very quickly, but I'm going to check to see. Okay, so I'm going to get you second on this one, Miss Rudderham. Miss Vizenzi? How bad did I? Vezina.
I just open by saying that the Office of Addiction and Mental Health does aim to address the call to action, which would be number 18, by working closely with Tajikeimɨk and the Nova Scotia Mi'kmaq Health Directors in developing universal mental health and addictions care. Clearly in its infancy, but we want to ensure that universal mental health and addictions care is provided in a way that's appropriate for our Indigenous communities.
Ms. Rudderham with a minute and a half, roughly.
There is no plan, there is no strategy, is my first point. There needs to be an action plan. There needs to be a strategy with the government of Nova Scotia on how they're going to respond to the TRC, because it doesn't exist. It's very piecemeal.
Thank you. Emily Burrow with a minute, roughly.
No, thank you very much.
You're done? Yeah. Okay. Emily. Of course you could. Before I said that over, MLA LeBlanc, and I'll still give you the minute.
Thanks. I just wanted to unpack a little bit about the previous answer. When you were saying, Ms. Julian, the crisis response would look different in your community than it would out like from, settler healthcare. Can you just give us a quick example of what it might look like?
Ms. Julian, like 30 seconds.
Really quickly, it would be community members responding in community. It would be them coming into community, not just going and sitting at the health center. It's going over to the family members, going over to the friends, seeking out those close ties to the person who either attempted suicide or was a suicide, stuff like that.
Awesome. Thank you. Emily Palmer.
Thank you. Ms. Peach, I don't know if you remember our question that what I asked you. Would you like to just sort of finalize that on how promotion of, yeah.
Ms. Peach.
Thank you. I was hoping you might come back to that one. Yeah, I think I was speaking about the cohorts. So there was one program done in collaboration with Cape Breton University with a nursing cohort based in Eskazoni. That's resulted, as I understand, in a significant number of Mi'kmaq students in the nursing program, more than they've seen before as a result of that work. There's also work that's been done with the Nova Scotia Community College and a Mi'kmaq Indigenous cohort based at the Pictou campus. That's work underway that we're also hoping will increase the number of Mi'kmaq LPNs and Indigenous LPNs. There's also been similar work done with continuing care assistant programs, particularly Eskazoni as it's opening up Gatineau, the new long-term care facility, that there was an interest in sort of recruiting and promoting health professions. So lots of work done by different organizations, but all supporting that goal of increasing the number of Mi'kmaq health professionals.
Emily Palmer.
Thank you. I have one last question, and I'm going to maybe have an opportunity for Ms. Wadden, who's been just patiently waiting for a question to come her way, and for maybe and representatives of the IWK as well. So in preparing for the meeting here today, I discovered that that there's about 8 patient navigators looking for in the Indigenous Patient Navigator program. Could you tell us a bit more about that program and tell us, what parts of the province they'll be involved in? And is that
Ms. Wadden?
Thank you for the question, Mr. Palmer. And just to note, it is a privilege to be able to sit here with our colleagues and hear and continue to learn from the group. So happy to be a participant during that. The Indigenous Patient Navigators is definitely an initiative that's come through Nova Scotia Health and not specific to mental health and addictions program. It is my understanding that it is an attempt at making those connects and making that access to services more conducive. And I believe there is 2 per zone, but I'm not entirely sure. I know that they're still in the recruitment phases. It's very early in the work. I know from a mental health and addictions program lens, we look forward to the opportunity of how we can integrate and leverage that role in individuals who are accessing and receiving care and support through our mental health and addictions program through Nova Scotia Health. Apologies, I don't have more information just yet on those roles, but again, I think it's demonstrating a recognition of the need to have further navigation coming from Indigenous individuals within Nova Scotia Health.
MLA Palmer?
I believe Ms. Peach may wanted to take a stab at that.
Ms. Peach.
I can add a little bit in terms of responding to the question around the allocation. So there will be 2 in Central Zone, 2 in Eastern Zone, 1 each in Western and Northern Zones, and 2 at the IWK. And those roles are very much to support the clinical navigation, and we'll work with colleagues within the health system to sort of prioritize the program areas, but also acknowledging that they will have a role to play in identifying some of the themes of what's working and what's not within the health system, and being able to advise leadership where they're seeing examples within each of those zones and organizations about work that needs to be done to address racism. So we're looking forward to those positions.
Apologize for the construction noise, that's annoying. MLA Palmer.
Thank you, and thank you all again for being here. Before I pass it on to my colleague, just say I think the summary I'm getting today from everyone here is that there's progress being made, more to do, and I think there's a willingness amongst everybody to pursue that more to do part. So thank you very much for being here. I'll pass it on to my colleague.
MLA Young with 4.5 minutes left.
Thank you, Mr. Chair, and thanks everyone for being here today. It is quite informative. I have a question for the Office of Mental Health and Addictions. Just wondering, is there any other initiatives or programs that the Nova Scotia government implemented to address mental health and addictions issues among Indigenous communities, and how are they funded and prioritized?
Ms. Vezina.
Thank you for the question. Before I start, I want to recognize up front that sometimes kind of naming off in our investments can sometimes feel a little bit tokenistic. So apologies to my First Nations partners at the table. It's not the intention, and it's the beginning. So we're starting, and as you mentioned, we're open to the collaboration. But a few areas that we have been working on is access to psychiatry services. So we've been working with NSH and DHW's physician services and Mi'kmaq communities to increase access to psychiatry services. As Sharon mentioned, we've also been working with Eskazoni over the last 2 years with regards to investing in the Eskazoni Crisis and Referral Center. We've also been working with Eskazoni for a few years, actually, and our IWK and NSH partners at looking at pathways from Indigenous communities and services into NSH and IWK health services where required. We have been working with colleagues at DHW in supporting the development of a health equity framework. We also have invested most recently in a Mi'kmaq clinical services pilot, and work is underway right now that includes a jurisdictional scan of similar programs and working very closely with Tajikeimɨk and First Nations directors to look at identifying what we could possibly do in that area. The Tajikeimɨk Mi'kmaq mental health and addictions strategy as well work, which Lindsay has spoken to, and so government has been providing investment there. And as Sharon pointed out, the truth and reconciliation and the call to action 18 is broad and beyond us, but we certainly will show up, and we have that commitment to continue to work together with our First Nations partners.
Thank you. Emily?
Thank you.
Okay. So does anybody have any closing remarks?
Mr. Chair does.
Well, no, not yet. I need these first. Ms. Benza?
Just, a few words, and I say this humbly and with humility, that we're learning, and we're committed to learning more, and we're also committed to collaborating with our First Nations partners and embracing them, leading the way for us. It's a changing environment that we're working within, and we have to consistently be looking at new and innovative ways to work differently with our partners. We're committed to the hard work, and we'll show up. So thank you very much to all my colleagues that are here today.
Thank you. I know Ms. Rudderham put her hand up. I'm going to check in the room first. No, Ms. Rudderham, you get the final say. So, Ms. Rudderham.
Thank you. Well, Alan, thank you so much for the invitation to provide and share our experiences on behalf of our Mi'kmaq Nation. We really believe, I just want to reiterate again, we really believe that moving mental health and addiction services out of the emergency room needs to happen ASAP. We also highlighted the importance of the need for Mi'kmaq translation services and access to our language. And also, most importantly, that we needed to support and provide community-led mental health addictions and crisis response services in our communities to ensure that these services are community-led and culturally safe for our Mi'kmaq. And maybe that does require a commitment, around looking at the TRC recommendations and to ensure that they're put in place. Maybe we do need senior leadership, Mi'kmaq senior leadership at various levels within the government and health authority structures. Thank you.
Thank you. On behalf of the committee, I'd like to thank all of you for coming. I'm sure everybody's learned, maybe not as much as I just learned, but I'm sure everybody's enjoyed it. You're now free to leave. We're going to take a 3-minute recess, and then we'll be back to deal with that. So at 10:45. So we're in recess. Order. Okay, the committee is back. Next page. I'll keep my notes this time. Okay, so we have some committee business. I'm going to deal with that first. The approval of the annual report of 2023. This was previously circulated twice to the committee. Does anybody have any comments or discussions on it? Okay, is someone prepared to make a motion for the standing committee to accept?
And table.
Oh, sorry. To accept the 2023 annual report as circulated and that the chair table it to the House of Assembly. MLA Barkhouse.
I'll make that motion.
Sorry. So it's been moved. Any discussion?
Do you need a second?
No, only in committee, but you would have caught me on that one. All in favor, aye? Aye. Contrary? Motion passed. We've received correspondence letter from Minister of Health and Wellness in response to the committee request during September 12th meeting arising from the correspondence from Matthew Casey. This was received on October 17th. It's distributed to the committee. Does anybody want comments or questions on it? Oh, okay. You can, but correspondence, October 18th email from Strongest Family Institute. This was received October 18th and distributed to the committee. Does anybody want to comment? Nope. Any other business? And MLA Regan?
So I think I would like to put a motion on the floor. Based on what we heard here today, I think we heard loud and clear about the need for more Indigenous Mi'kmaq representation in the upper echelons of Nova Scotia Health and IWK Health. At DCS, several years ago when I was still minister, what we did was we actually implemented a position for an African Nova Scotian advisor on our executive team so that when we were making decisions, we had that lens on what we were doing. And I think it improved our understanding and moved a lot of things forward and gave us better understanding of the issues. And also sometimes you don't even think about something because you don't know what you don't know. So I move that the chair write on behalf of the committee to the Minister of Health, to the acting CEO of Nova Scotia Health and the CEO of IWK Health to let them know what we heard about the need for Mi'kmaq representation in the higher levels of the health system and encourage them as a starting point to each of the health authorities to appoint a Mi'kmaq advisor to the executive team of those health systems.
MLA, sorry, thank you. MLA LeBlanc.
Well, I just want to say that I would support that wholeheartedly. Just a nice letter. No challenging, just, what we heard and what we think should happen. Great.
MLA Palmer.
Thanks. So just a little confused. So you want to write, what you're suggesting is the committee, through the chair, write a letter to Minister of Health.
CEOs of the 2 health authorities.
Mm-hmm.
Let them know.
Oh, just a sec. Emily Reagan.
See, A, it's Regan, and B, we both knew that was going to happen, right? Right? Not Reagan, Regan. Okay.
I apologize, Emily Regan. Sorry.
Okay. So that we write to both the CEOs and the Minister of Health, let them know what we heard from the Mi'kmaq health experts who are here before committee today about the need for there to be Mi'kmaq representation at the higher levels of the health systems so that when they're creating systems or programs or whatever, that Mi'kmaq perspective is included and when they're creating programs for the Mi'kmaq, that there's a lens on that, and encourage them to do this as a starting point to actually appoint advisors to each of the executive teams in those two health authorities.
So I just want to be clear on this one. You're wanting to write a letter, not to let them know about it, and then request that they do this, or are we just doing this as a letter for them to understand what we've received? So as chair, I'll get you next.
I would
Just to be clear.
encourage that we would encourage them to consider doing this.
Okay, hold on. Thank you, Emily Regan. Good catch. Emily Palmer, sorry.
Okay. So just like we've clarified it enough. I guess we don't need to banter it around much more. The letter will have a call to action or just notification of what you want a call to action letter. Yeah.
MLA Regan. Just, I'm going to get her to answer and go back to you.
Actually, I'd like to hear Mr. Palmer.
MLA Palmer.
No, I guess my point is there's a bit of a distinction there, right, between the call to action and then just notification. I mean, I'm wondering if it's an opportunity for another committee meeting at some point in the future to topic selection or anything like that to bring forward. But I mean, we can support this, Mr. Chair.
Okay. And MLA Regan, I just want to be confirmed. You did say it's both, so I just want to, because MLA Regan.
It is both.
Okay, thanks.
It is both an information and a call to action. I'm not sure we need another meeting. I think we heard plenty here that underlined. I mean, we would probably need another meeting to check on the progress, what progress has happened after this. But I really think, there's a lot going on in the healthcare system, and our role here can be to assist the CEOs and the health minister. When we hear a good idea, just bring it to their attention.
Okay.
This could be better.
Emily Nickel.
Thank you. And anyone who knows me knows I don't like meetings for the sake of meetings. So therefore, to do this, we'll just respond in a governance way as a letter back to this committee. So it's not necessarily, all the heavy lifting being done by this, this letter. It's just going to come back here in a letter as to what could be done, what will be done.
Do you need to still, or am I going back to MLA? Oh, sorry. Oh, MLA White. Thank you.
Thank you. I like to speak from what I know, not from what I assume. And I really like the idea of expressing what we heard today. I think community involvement is key to everything. I can support that, what we heard. But a call to action, I don't know if there's any action already been taken. I really don't know that. So if that's what you really want, I don't know if I can support that. I can certainly support what we heard. So what I'm asking is that MLA Regan get to tell us a little bit more what she wants, because I really am confused which one we're asking for. Tell us which one you want, and then give us a recess to think about it for a second. Please.
MLA Regan.
As I said originally, that we write a letter, we tell what we heard here today, that the health authorities add as a starting point a Mi'kmaq advisor to the executive teams of both IWK Health and NS Health. If it's already being done, they'll let us know, but from what we heard today, doesn't sound like it's being done, right? That's right, we don't know. So they may write back to us and say, look, it's already being done, in which case, no harm, no foul. But at the very least, we heard some things here today. We heard about young people dying of suicide. We heard about things that need to happen in the healthcare system, and a good way to get that rolling is to actually have Mi'kmaq advisors in there saying, look, this is what you need, this is a problem, this won't work, this will work, that kind of thing. It really helped us at DCS when we brought someone in who had a different perspective than everybody else sitting around the table, and it led to more change, I believe, at DCS as a result of the fact. So it should not, this is not a big ask. It's not meant to embarrass anybody. It's to make the healthcare system better.
And just to let everybody know, the clerk will not be summarizing. She would send a transcript of this to them. She's not going to summarize because obviously, so I just want to make that clear. Yeah. It's not going to be anybody's view. It's going to be, here's the transcript, the letter, your question. That's what would be attached. I just wanted to let you know, so
Super.
at least,
Yeah.
well, at least everybody knew, because if somebody said, well, I wanted to summarize, yeah, it's not happening. We're just going to send a transcript of it. Just a sec. MLA Palmer?
So I'd like to make just a little amendment to this, if I could. So what I'd like to propose is requesting a letter from Department of Health and Wellness asking for an update on the hiring practices of what we discussed today, highlighting what we heard, but asking for an update from what they're already doing about this that could be presented to or read by you, Chair, at a future meeting at some point. But just the letter would not be a demand, but it would be asking for a requesting what's been done.
So just...
Well, what's being currently done by the department in what they're doing.
Okay. Well,
I made an amendment.
And just a sec. MLA Burrow, on your point of order.
This is not an amendment. It is an entirely different motion, and therefore I question whether it's in order.
So I was about to ask the member a question before you did that, so I'm going to go back and ask him. So, Emily Palmer, are you saying, as opposed to requesting that they have one, an advisor of Mi'kma'ki, what is their status on having that in place, or are you going, I'm just trying to...
Just basically, I think what I'm asking, if we can amend, if I could propose an amendment to the motion, if that's possible, just suggesting that we ask for an update on the practices of what, in relation to what we heard through this meeting.
So instead of asking for a request for them to do that or think about it, you're asking for them to update what their status of doing it is?
That's correct. That's what I'm asking.
Okay, so I'm going to ask this guy a question. Okay, so I've confirmed with, on my clarification of what MLA Palmer is, that's not out of order because he's not changing the intent of it. All he's saying, as opposed to saying, I want you to do it, he's saying, would like to know the update on you doing it, correct?
That's correct.
So that's the amendment? So MLA Regan.
I don't have an objection to adding that to the letter, which I have proposed, but I do think we should ask for an advisor on this. If they've got one already, great, they'll tell us. But certainly say, you know, what are you doing around this? That's fine to have that. I'm sure they would include it anyway from everything I've seen. They would include what they're doing in any response. But I do think it's important that we note there should be Indigenous, specifically Mi'kmaq representation on the executive teams of the two health, what are we calling them? Health board? What is it now?
Sorry.
Authorities.
Never out of time here.
So we need to vote yea or nay.
So, but I think his is just as opposed to the request. He's saying, what's the status on doing that? That was his amendment. Correct?
Or we could have
All right,
made a
so-
recommendation for them to do it.
So,
Yeah.
time is met. The next meeting will be Tuesday, November 14th, from 1 p.m. to 3 p.m. Note, if the House is still sitting that day, the meeting will be held 9 a.m. to 11 a.m. The topic is home care and community care. Witnesses are the Victorian Order of Nurses Canada, Department of Seniors and Long-Term Care, Nova Scotia Nurses Union, Canadian Union of Public Employees, Nova Scotia. This meeting is adjourned.
So speaking of